working? Should I move close enough? Tá funcionando? Posso começar a xingar então? Can I start to swear then? Should I get going or what? Yeah.
That's us. So, welcome everyone. We are here for the second of privatization health system. It's funny that we will have more people watching than actually here, but at least they will participate on either Skype or WhatsApp. We have two groups in Brazil watching, and some people also in Europe, in Germany, watching too.
Yep, Fabiano.
So I would like to thank you, Eduardo, for coming. And thanks, Elias, for also accepting to come today. I will let you introduce yourself because I think you are a Fulbright scholar. You are from the University of Massachusetts and work with health system, comparative health system. So please, the floor is yours. I will make this more formal.
Sounds good to me. I'm a very informal guy. My middle name. So it's a pleasure to be here. And what we had agreed to do is to take advantage of the studies that they have been doing here, as well as some of the studies we're doing, several of us here in Brazil, to lay out some issues that we are concerned about. And just for disclosure, this is not a presentation that I developed. I rely on this group in the United States called Physicians for a National Health Program. I am following this group for a long, long time. I believe they are the best representative groups in terms of showing us the problems that you have in the US healthcare system. And they are actually very actively pushing the agenda for what we call the single payer. So I asked them for a short presentation. They gave me 130 slides. This is a presentation for the public. I cut already in half, so I'm not going to probably show every single one in detail because I know that our focus is privatization. They touch on this during the presentation, but I have to give some background because I'm not sure how much people know about the United States health system. So some overall idea of what's going on, and then we focus more on the main issues that are the scope of our collaboration here. So first of all, as you know or heard about, we have a significant number of people without health insurance in the United States. This number decreased over the years and then it went up, and now we are in a situation where it's picking up a little bit, not too much given the latest reform, but the ballpark idea is that we have tens of millions of people without coverage in the United States, which is not usual in most countries in Europe at all. If you break down how this impacts health, the estimate we have for 2017 is that in some states of the United States, the lack of insurance is related to excess of deaths, especially in states such as Texas and California or Florida, where you have a significant number of people without insurance, and we have studies that show because they do not have insurance, they die. And we are talking about this number here in 2017. In other words, not having insurance can kill you. That's a short version of this. As far as this program called Medicaid, which is a program that covers the lower income population in the United States as well as nursing homes, you see that the numbers of people covered are very high. We are now close to 70 million in a population of about 315 right now. About this is the number. So about a quarter of the population, give and take, are covered by this program, which is typically one of the welfare systems that you have in Europe for low income. And as you can tell, this number has grown. A lot of it has to do with coverage of the elderly for nursing homes. So this program is very important. It also covered populations with AIDS, populations with disability. Over time, the government was adding populations to this program in order to increase the coverage for those who could not afford to have insurance. one of the problems we have with this system is, as you see in any country that has a two-tier system, is if you are covered by Medicaid, there are a number of children, as you see here, that are covered by public insurance that are not seen by physicians, by specialists. If they have private insurance, they are seen. If they have public insurance, they are not seen. Why? Because the levels of paying for public insurance are lower than you have private insurance. Then the number of specialists available are lower, and many specialists do not want to have to help or to provide service to this population because they don't make enough money. The private insurance is much a better deal, and that's why you see this discrepancy. The idea being that if you are covered by the public system, you may have good overall coverage in terms of what you're covered for, but you don't have necessarily real access to the coverage. So, broad message is, if you have underinsurance, you do not have access, your health worsens, and in the United States, which is one of the few countries in the world, you can actually go bankrupt because of expenditures in healthcare, which is a scandal. It is a significant problem for a number of people in the United States. So, what we're seeing over time, this is recent data, the number of people underinsured is growing. What do you mean by underinsured? It means that they are not covered for significant diseases. They have less. A test of how much I love the United States. I guess that's what it is. It's showing me that I do not love that much. So the underinsurance is growing, which is a problem because what happens with many people is they believe they're covered until they need the coverage. And then they figure out once they need the coverage that they have to pay more out of pocket. The insurance doesn't cover this, doesn't cover that. For those of you who are in Europe, you have a lot to learn about private insurance by taking a look at what happens in the United States, which in Europe is a complementary coverage. In the United States, it is the main coverage for the majority of the population. What that means is even if you have private insurance coverage, you still may be uninsured. Many plans now pay nothing for out-of-network care. I don't know if you're familiar with the idea of the networks, but insurance plans actually provide you a network of physicians and hospitals that you cover. When you buy insurance, you select what kind of insurance you have, and that means you are covered by a group of physicians, hospitals, services that are within that network. If you are outside of the network, you are not covered. You have to pay a lot more out of pocket. So what is showing here is that if you are out of network, especially if you have individual plans, that means you pay yourself individually for the coverage, a lot of them do not pay anything for out-of-network care, which means if you need care that your network doesn't cover, you go out of network, they are not going to cover all the expenses. That means you have to pay out of pocket. And many people are surprised because sometimes the specialist they need is not in their network. They have to go somewhere else, and somewhere else they're not going to be covered, which means they're going to spend a lot of money out of pocket. If you are in a small group plans, which is plans that cover a small number of people, you also have this problem. What that means is, for example, I'm a faculty at a public university in Massachusetts. I belong to a pool of people covered by insurance that covers all public employees in the state. It's a huge pool. So I'm not in a small group plan. The insurance plans that cover us covers tens of thousands of people. So I wouldn't have this problem. But if I'm in a small business, have 50 employees, let's say, and then I buy a small group plan, I still might have a lot of problem, nothing covered if I need a specialist that's not part of the network. This is a bit more complicated, so I'll go in passage just to give you the main idea, which means depending on the plan you have, you may not have the coverage that you need, and you end up paying a lot more of your out-of-pocket. Now, regarding again the issue of uninsurance or uninsurance, what you have is, for the uninsured, it takes longer for the same disease, in this case, heart attacks. So if you are uninsured, it takes a lot longer. The idea, depends on the type of insurance. Your heart attack will be dealt with differently. which means, obviously, if you are insured, compared to the insured, these groups have delays in seeking care. What it means is it takes longer for them to get the care for heart attack, depending on the kinds of insurance that they have. And this applies for a lot of diseases. This heart attacks is just an example because obviously you need immediate care. And still you can have delayed care if you are uninsured or uninsured. The issue that I mentioned before, 59% of people who get calls for bills that are not paid are because of medical bills. So in other words, in the United States, many people end up going bankrupt, or they have more calls from medical related issues than from telecommunications, than from utilities, than from taxes. In other words, look at the difference, it's huge. So medical bills are the main issue that people get calls from collection agencies. Collection agencies are companies that are paid just to call you, to bug you to pay the bills that you didn't pay because you didn't pay on time. And that shows you how important medical care, medical bills are in the United States for the agencies that collect this money. Now, moving right along to another public program that we have in the United States that covers seniors after 65. It's talking about Medicare according to the income you have. So, the main point for this slide is for many seniors, medical costs consume more than 1/5 of their income. So what happens? You retire, your income is lower. You get Social Security from the United States government. But the money you pay just for health care is over 1/5 of your income. And it gets worse depending on how much money you make. So it can get 40%, 41% of seniors that spend at least 20% of their income, which means they end up spending too much money on medical care, which means they don't have enough money to pay for rent, to pay for food, to pay for transportation. So we have a big problem growing in the United States. And the other issue that I want to call your attention is the federal poverty level for a family of 4. This is the value. $25,000 for a family of 4, which means the threshold for you to be considered poor is very low. You have to really be very poor to be considered poor in the United States. Most countries do half of the median income. It's considered to be okay. Here it's below that. So what they do is they have a very low threshold, which means they only cover people who are really very poor. And there are a lot of people who are poor and not going to be covered, or they're not going to get enough support from the state, from this program called Medicare, to support what they spend on health care. So this is the median income, and of course you all know this, the inequality. We are now at levels only seen in the 20s and 30s of last centuries. 100 years later, we are having the same levels of inequality, a major problem in all societies. And as you can see here, those at the top are the ones who are actually getting more of the money, according to each, for quintiles, right? So the mean family income, the discrepancy between the top and the other quintiles is enormous. So the real issue is what we call in the United States the 1%. Income in the 1% keeps growing. Everybody else either stays flat or increases a little bit. So most of the population, 90% of the population, are not seeing their income increase. At the top 20, we have some, but the real big issue is this crowd here. This is the crowd that's really getting most of the growth in the economy and getting the benefits from it. And that is shown also according to income, in life expectancy. We all know that money makes your life longer. If you have a lot of inequality, those at the bottom will live less. And this slide shows very clearly, if you earn below the median, you see the remaining life expectancy after 60. It is increasing for everybody, but look at the difference in this curve. In other words, after 60 years of age, if your earnings are above the median, you will grow. You have an extended life, longer life than those who are below the median. And you can see that the curve continues. As inequality grows, this curve grows apart. The point being, as we know, inequality creates any number of impacts on health, and this is about how long you're going to live according to the income you make after 60. Now, you all probably heard about this. Recently in the United States, the decrease in overall mortality per 100,000 has stopped. We are now seeing some increase recently. Some people are doing studies and saying this is clearly related to inequality that the country is experiencing lately. So we see a trend for decreased mortality until very recently it's getting flat, and we have already evidence for some parts of the population is growing. Suicide being one of the reasons that people are talking about. Suicide, desperation, the opioid crisis that we're having, addiction to opioids. So especially for adults, whites, and middle age. This is well known in the United States. If you're black, your life expectancy is lower than Hispanics and whites. Hispanics here include all the Central Americans, South Americans, Mexicans population. So they are in the worst conditions there in terms of life expectancy. Also, differences in maternal mortality. Just to give you an idea, the black or white issue in the United States continues to be the major issue in the society. And for every single indicator that I know of, blacks do worse than whites. It's unbelievable. Chronic disease, acute disease, you name it. And this is just some of the pictures that to show you that this is a pattern that we see. Now, I'm coming back. This is the median income, whites and blacks. And as you can see, there is a discrepancy. All incomes have grown between 47 and 2010, so a long period of coverage. Inflation adjusted, so it's not an issue that doesn't take into consideration inflation. But still, the gap continues to exist throughout the last 60 to 70 years. Now, regarding immigrants, which is another issue, big issue we have in the United States. If you are US born, you get more health care, you get more emergency care, and children also get more care. So comparing foreign-born immigrants to US-born, the immigrants always have worse, and this is the amount of money spent per different group. So also showing a disparity, inequality, inequity regarding immigrants. Now, on the other hand, a very interesting issue is a lot of immigrants contribute to this Medicare program, which is the program for the elderly. But they don't get, because they live in the United States for a certain time and they go back home. And what happens is because Medicare is paid out of your income, out of your wages, they contribute. And if you compare what they contribute versus what the US-born contribute, actually, there is an enormous amount of money that foreign-born and non-citizens contribute to this program to keep it afloat. One of the major discussions we have in the United States is if Medicare is sustainable or not. Should we cut benefits, increase the age, etc.? But then many people said, oh, these immigrants are draining the funds that we have in the country to support the US population. Then when you look at the data shows that immigrants are contributing actually for the program to stay afloat. And this is something that most Americans don't know, and they blame immigrants for the resources that they take, but they don't realize that they're leaving behind a lot of money that will cover the elderly. Now, moving on to another topic, the issue of overhead. Overhead is what you have expenses with administration for insurance companies, right? They keep rising. So, in terms of administrators and physicians, you see the curve for managers and you see the curve for physicians. So what you see in the United States, let me go back here, is an enormous growth on administration since the 70s, 3,000%. And look at the number of growth of physicians. So a lot of this discussion about effectiveness, efficacy, new management, what you're seeing is an enormous growth of people who manage healthcare and not a significant growth in those who actually provide care. And this is happening everywhere. The example of the United States is probably the extreme, but from what I've been hearing in Europe, you're trying to copy this shit. Oops, sorry, I shouldn't have said that. Copy this model, a very bad model that we are fighting against. When I say you, I'm not referring to any particular country, but that's the trend that I see coming here. Follow the bad example. So in terms of paperwork that the physicians spend in the United States, 48% of their time is dealing with electronic records, bureaucratic work. And most physicians are fed up in the United States. I've been hearing for a lot of them. Many of them are saying, I don't want to be a physician anymore because I was not trained to do that. I spend a lot of my time doing stuff that I don't want to do, and only 26% of the time with patients. So there is a undersupply of primary care physicians, and they are still burdened with a lot of this stuff. So they do not spend enough time with patients and a lot of time doing other stuff that they don't believe they should be doing. You increase administration, you increase the paperwork, a lot of overhead, and that's what you see in this slide, reflecting this slide. Now, moving to the main topic of our discussion here, for-profit care, investor-owned care. The summary is we have inflated costs and inferior quality. Many, many studies comparing private for-profit with other care, and you're going to see some of the results here. For-profit ownership. The major areas where they go is where they can make a lot of money. So what is this? Freestanding imaging, all the MRIs, X-rays, all the imaging, the whole technology. Dialysis, surgical and urgent care centers, skilled nursing. General hospitals, just 13%, specialty hospital, 36%. But all those are giving a lot of money, and they have become increasingly for-profit, including, unfortunately, hospice, which is what we call palliative care. When you're close to die, you have cancer, you have no treatment, you go to hospice. A lot of them for-profit. Now the profits. For those of you who study healthcare, we can not only talk about the services provided, but who makes the money in the industry, as we call in the United States. And as you know, the United States has the most expensive drugs in the world. Insurers is a huge sum of money, and then pharmacy, equipment, supplies, and distributors and wholesalers. Those are the folks who get the products from the drug industry and distribute. And we are finding out that a lot of them are the ones who are responsible for the increased prices. They buy from the companies, and they add some profit in the drugs, and then they distribute, and then there is increasing prices. And you're going to see some examples here of specific examples on how this happens. So this is a comparison of for-profit hospitals with other hospitals, and I won't have time. This is all literature that was published, peer-reviewed in the United States, and you see that in for-profit hospitals, death rates are 2% higher. I won't have time to go in detail, but this is a very good study that compares private for-profit with private non-profit, and got several studies, that review of several studies that show where the estimates were in the odds ratio, and what they figured out overall is 2%. There's a 2% increase death rates in for-profit hospitals. Highest readmission rates. So in other words, what that means is if care is good, you shouldn't have people come back to the hospital. If they're coming back, there's something going on here, because when you compare non-profit, public, and for-profit, the for-profit have high readmission rates for any number of diseases here, from pneumonia, for joint replacement, heart failure, COPD, chronic obstructive pulmonary disease cabbage, which is what you do when you have blockage in your arteries, coronary artery, etc. So for every single of those, the for-profit have more readmission. It says for every condition. And of course, this is all relative, comparing one versus the other. Another study showing in terms of cost, 19% more. So 2% more death rates, 19% more in terms of cost. Review of the literature. So in other words, being a for-profit hospital, you can make a lot of money. And in the United States, we have many examples of this. Now, if you compare administrative costs, also not a huge difference, but they spend more money on administration. If any of you visit a hospital in the United States, you're going to see a whole floor full of people whose only job is to manage paperwork, bills, a significant infrastructure, because there's so many insurance plans, so many providers, and they have to basically get bills, bill people. It's an enormous amount of people, which is also a problem for us, because if you want to change the system, you have to find jobs for these people. You cannot say, I'm going to change the system and forget the hundreds of thousands of people who work in these kinds of jobs. A lot of administrative, and part of it is because the system is very inefficient. Although it claims it's more efficient, it's not. It's very inefficient. You need a lot of paper pushing, and that's what happens with insurance companies. Now, if you compare relative risk of hemodialysis patients, right, in clinics, also if you compare for-profit with others, 9% higher. So in other words, they're more expensive, and when you look at the outcomes, they're worse. The worst outcomes, several studies. Now, hospice is what I just mentioned to you. It has become a significant source of profit. What that means is when you need the most care, when you need a lot of care because you're close to dying, people are making a lot of money out of this kind of care. Those are people who basically are kept alive by painkillers, all kinds of medications so that they can survive while you know they're going to die because they have cancer, because they have diseases that are actually going to kill them. But the trend has been, obviously, they found out that this is a good source of profit. And what they do, they avoid unprofitable patients. So this is a graph that shows the likelihood of accepting all patients regardless of the care needs and profitability. And what you see is the public gets everybody. They don't deny care for anybody in terms of hospice. And when you get for profit, they actually select people that they accept. So this is one way when they make money. They select the groups, they select the clientele, and that's what we always say. When you have these kind of so-called competitions, one of the ways to compete is you exclude from your care the patients that are more expensive. And we have this all over the world. People do as a way for you to make profits, get the patients that are healthier, that will be less cautious so that you can make more money. That's basically what it is. And this is, they accept less the patients that are unprofitable if you are a for-profit institution. This you probably heard about this. The US by far is a country that spends the most on drugs. The argument from the industry is that because we do more research. So because we do more research than other countries, we should be paid more. But we have plenty of evidence that shows this is not the case. And the country that we typically compare the most, because it's our neighbor, is Canada. And you see there's a big difference. The UK is definitely lower. I'm not sure exactly where here, but the UK is much lower. You pay for drugs much lower, much less than you pay in the United States. This is an example that I wanted to show. We are now fighting this because people are dying because the price of insulin is too high. They have diabetes and they can't afford to have it. So there's a group in Massachusetts doing a campaign. It's called the Right Care Group. And the fight is they are basically doing this. They're going to the door of the company and say, okay, these are the people who are killing. Actually, they brought the ashes, which was a very creative. They brought the ashes. The family came and said, look, this is the people you killed because of the prices you're charging for insulin. And as you can see, the prices have increased dramatically. There's no excuse for that. There's no explanation for that, why the price is so high. And actually, this price is much lower in other countries. If you take a look at how much they charge from insulin in the UK, you're going to understand what I'm talking about. It can be 10 times less, 20 times less. This is a ridiculous price that they're charging here. Now, drug company profits. It is the best country in the world to be a drug company. And as you can see here, comparing the Fortune 500 countries in the United States, the median return on revenue, which I'm talking about profits, the drug industry in the United States always makes a lot more profit than the other industries. It's a very good business to make money in the United States. Now, moving to another issue, this is what Goldman Sachs said about hepatitis C vaccine. I just want you to read because it speaks by itself. So it clearly shows that for the industry, they don't want really you to be healthy. You want you to be sick so that they can make more money. And this is clearly say hepatitis C is not necessarily a good deal because once you vaccinate everybody, you don't have more people to vaccinate. So curing people is not really what you want in order to make money. You want more people to be sick. And we all know that behind closed doors, that's what they talk about. They want, as we say, captive audience, a disease that's chronic, that they have to give to drugs their whole life. They don't want to cure you at all. The more people who will consume their drugs, the better. Although in public, they're never going to say this. When you look in records, you go to court, you see what they talk to each other. That's how they say. That's what they say. Now, the other stuff that I mentioned to you is insurance overhead. These are for-profit groups. Some of those get into developing countries. As you can see, the numbers are very high. So what they call medical loss is the amount of money that they actually cover people. So what they call a loss is if they cover you, for them it's a loss. So the higher this number, what they're telling you is we're spending too much with people. That's what they call a loss. It's a contradictory term, but what they mean is if you have a higher medical loss, that means you're giving too much coverage to people. You want to have a lower medical loss. You mean they're spending less money to cover people. And this is the lingo they call it. And a lot of this, we want actually to be this 95%. Most of the money that they get should be to cover, to provide services. And that's not what this is indicating. What this is indicating is they consider a loss when they actually provide coverage for people who need. Which makes sense from their perspective. From our perspective, it's outrageous even to call this a medical loss. Now, these are some examples of how much they make, the CEOs. So some of them make per day more than any of us would make per year. This is the median income of a full-time wage and salary worker in the United States, $43,000. These guys make per day more what the people make per year. So this is how much money they make. And the justification is the shareholders are making a lot of money, I should be paid very well. The shareholders do not make a lot of money, I still should pay very well. There's no relationship between the pay of the CEOs and the profits of the company. This relationship has been broken for a while now. Unless it becomes a scandal, unless they are trying to create a drug that the drug fails, and then evidently the shareholders punish them and the CEO is fired. But when they are fired, they take with them a lot of money anyway. Now, as far as Medicare, the issue of efficiency, because there's always this issue comparing private versus public. This is the biggest public program of coverage in every United States. It's more efficient when you compare it with private insurers. So some examples here. This is one type of Medicare. I wouldn't have time to go in detail, but just to give you some idea. The overhead is very low. When you go and include companies to provide, the overhead go to 9%. So in other words, they have to take a chunk for profit, a chunk for overhead. When you have a public provided service, the overhead is very low. The vast majority of the money goes for the patients, for people who need. That is a big difference. When you include companies to manage care, which is what happens here when you have this program called Medicare Advantage, you can see that some of the money, significant amount, goes either to administrative costs or profit. And then we compare what they cover. When you have the traditional Medicare, which is a coverage that is provided by the government, 100% is covered. When you go to Advantage plans, depending on what plan you have, you may have different levels of coverage. So the type of network that you have can be very narrow. In other words, you get a plan, but you have a very small network of patients or hospitals to cover you. Only 23% is broad compared to 100% if you don't have companies as intermediaries to cover you. And that's what happens when you, in Medicare, although it's a public program, they allowed private sector companies, for-profit and non-profit, to be the brokers, let's put it this way, the ones that organize the care. And what you see here is it's much better to have a coverage without the intermediaries to link you with the coverage. So in other words, it is more efficient and it provides you better care. Now, this is a summary of that slide. It's basically, despite Medicare's lower overhead, Medicare Advantage plans outcompete traditional Medicare by cherry picking, upcoding, and lobbying for overpayment. So I'll give you some ideas what that means. This, translated in plain English, talks about, this is corruption. Corruption can be very nice names in scientific literature, cherry picking, upcoding. This is all about corruption, how I make more money out of a single patient. So, what we are seeing here is the number of people covered by these groups called HMOs has increased to not a large number yet. I mean, I shouldn't say not large enough that already by 2015 we had about 20 million people who actually gave part of their money for companies called HMOs in English, health maintenance organizations, to organize their care for them. They are elderly, they want people to take care of the whole coverage that they get, and they pay fees for these companies, and it has been grown. And they typically are for profit, but they're private sector for sure. Now, what it shows here is Medicare, which is a public program, it actually supports a lot of the private sector. So in other words, the two big public programs in the United States, Medicaid and Medicare, they are the ones who actually support to keep the private insurers afloat. So this is the idea that they are not really private. There's no real market in healthcare. They are supported by public's money. They stay in business because they have guaranteed source of income that comes out of taxpayers, that comes out of your wages. You are keeping these programs afloat, both the poor and the elderly. The Medicare is for the elderly, Medicaid is for the poor typically. Money that comes into these programs keep the insurance afloat, mean alive, because without this source of funding, they would not really be able to survive, not to the level that they are. Which, as we say, the moral of the opera is that these are not real private sector as such as in other markets. These are markets that without the support of the taxes, without support of the government, they would not really be able to stay alive. Now, I'll give you an idea of what the upcoding is. Let's say this is a charge that they were supposed to be paid. The original, because as you know, in order to be reimbursed, you code the disease, right? In the patient chart. The base rate would be $39.50, right? For all, compare the two codes. Then when you compare how they code different, look how much the prices increases for what it was supposed to be and how they charge. So the patient may have all these complications. So what do? You get that patient and break down all the diseases the patient has in different categories, and then you end up getting a lot more money. So in other words, this patient has diabetes type 2, uncomplicated. And then what they do, if you have diabetes type 2 with a complication of diabetes, to make it, this is a complication of diabetes. I'm not going to get into much detail. What they do is they increase the rate and split the coverage in such a way that they end up with a lot more money. This is what we call upcoding. So depending on who is paying, the code is different. So when you talk about CMS, this is a government agency that actually says this is what the code should be. And then, actually this was Massachusetts actually. And then when you look at how they coded, what they actually did was they broke down the codes, increased the prices so that they can have a much higher pay for that disease. And this, when you compare the coding, they do all over the place. We found a lot of this as a problem. It's a tricky way to say, okay, this patient has this complication, but I'll say he has this plus that, and then I'll get more money. Instead of saying this patient only had this. This would be enough. But no, they break down all the other diseases associated with this to get more money. I'm not sure if I was able to be clear about this. That it requires that you understand what the complications of diabetes can be. You can have all these complications. A patient can have all these symptoms. But when I code each one of them separately, instead of saying this is a basic disease. By doing that, I end up getting a lot more money compared to what the original coding would be.
So they treat them as individual diseases?
Yes. Yeah, they break down. Yeah. They break down the associated issues and say, for each one of them, I'm going to pay a separate rate. And then they inflate the rate. That's why we call upcoding. Okay? Now we did this is happening in Massachusetts. We did an audit of the overpayment for plans. And what you saw was the plans overstated the risk score for 80% of the patients, resulting in overpayment for 58% of the enrollees. In other words, by doing that, you overpay patients $3,300 per enrollee, per person enrolled in insurance. Is this corruption? Of course it is corruption, but they do it, and you can have a lot in the books, but if you don't inspect, you're going to say, well, it's the market. The market's working. This is not the market. This is typical procedure of a cartel. They negotiate their stuff, and They bill and then hush, 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 nobody knows. Until somebody comes, and in this case was the Attorney General of Massachusetts went there, or the Senate, when they do the control, that's what they find. And look, I'm talking about 80% of the patients. They increase the risk so that they can charge more. And this shows the overpay that we know for the United States, $173.7 billion. So for those of us in Brazil who are comparing this new organization they're creating with the public, this is what happens in the United States. Nobody needs to tell me what's going to happen in Brazil. I already know. We're going to overpay a lot of the money because that's what they do. And upcoding is what's responsible in red here. This is what's supposed to be. This is what they do in upcoding. And we know, physicians know, that the growth in administrators is because they are the ones who know how to do that. They get the patient diagnosed and they break down so that they get more money. That's why the administrative people spend a lot of time doing. Now let me move on this, because this will take more time. I want to show this one, the issue that we're talking in many countries, the merging of hospitals. Independent versus system hospitals. This is a trend that's growing in the United States. The small independent hospitals are being swollen, eaten by larger system, larger hospital conglomerates. The other thing that may apply to other countries as well, the hospitals are buying the primary care practices. So the number of people who had their solo practice is decreasing, the medical groups are decreasing, and the hospitals are basically buying and making the physicians part of the network that the hospitals organize. And then when you do a hospital-owned practice, what you have is more technology, IT, higher costs, and more readmissions. Again, when you compare when physicians own and hospitals own, you see that when the hospitals own, they're more expensive. And as the system moves in that direction, it's more expensive it becomes. I believe this is a discussion that's relevant for the UK, the issue of pay for performance. This is a magic bullet that they found to make the system more performance-based. And the assumptions are the performance can be accurately ascertained. Almost impossible in healthcare. Individual variation is caused by variation in motivation. Not the case at all. Financial incentives will add to intrinsic motivation. In other words, if you put money on the table, the physicians will perform better. They are treating physicians like mice with cheese. Put the cheese here, then they'll become better, which I'll show you later. We have evidence this is not working at all. They become richer necessarily, but the system doesn't necessarily become better. They say that the current payment system is too simple. They have to pay for performance. They create all kinds of indicators. And they say that hospitals and the physicians are delivering poor quality of care. They should get fewer resources. In other words, incentives for those who perform well, punish those who perform poor, right? That's the idea of payment for performance. Now, when you actually do studies that show why the care is different, a lot of the reasons are related to who the patients are. If they are minority patients, the physicians get lower scores if they treat more minority patients. If they treat more non-English speaking patients, they get lower scores. If they treat the poor people, the people who have less insurance, they get lower score. If they have people who visit them less frequent, they get lower scores. So the performance of the physician is not determined by the physician. It's determined by what happens in the society. So if you say, I'll put more money for you physicians, assuming that that's what drives the issue, that's not what drives the issue. The fundamental issue is what kind of panels of patients, pool of patients you have. And you do the comparison, you see, well, you have to adjust according to what patients you have. This is a leader of this reform in the United States, and he says, I do not think it's true that the way to get better doctoring and better nurses is to put money on the table in front of doctors and nurses. I think that's a fundamental misunderstanding of human motivation. And by the way, I heard recently by a colleague in studies in business that this idea of pay for performance for business is already out of the way in many of the top level businesses. As an idea, it's still alive and well, but as a solid evidence that the business gets better, it's not really considered to be the golden standard. If you ask folks who are dealing with IT, high-tech stuff, they'll tell you that's not what motivates people. put ping pong tables, make them work in a very nice environment, give them ability to be free, to be creative, they'll get the best. Try to put money on the table, it will not solve the problem. I think people respond to joy, that's what he's talking about, in work and love, and achievement and learning and appreciation and gratitude, and a sense of a job well done. I think it feels good to be a doctor and better to be a better doctor. I am one of them, and I believe most of my colleagues would prefer to have this kind of joy than to say I'm going to make more money. Of course, I'm not speaking on behalf of every physician, but that's what you come to the profession with. That's your idea. When we begin to attach dollar amounts to throughputs and to individual pay, we are playing with fire. The first and most important effect of that may be to begin to disassociate people from their work because they start looking for the money. And then you have physicians who become bankers. And that's what I'm seeing in the United States. They spend a whole lot of money managing the business. They forget, they actually leave the occupation because they said that's not to be a physician anymore. So I might as well become a banker and take care of money, become wealthy. This is in brief what happened after the Obamacare, so-called. It's called the ACA in technical language. We have modest improvement in access and raised administrative costs. Why? Because it didn't change the structure of the industry. This is, of course, a joke in what the Republicans want to do in healthcare in the United States. GOP stands for Republican Party. What they really do is a mess. They have a mess of an idea. This is Trump's plan. Nobody understands. It doesn't make any sense. And it keeps coming from this angle, that angle. And what you're seeing, these people, you get sick, you die penniless. That's basically what he's saying. I'm not going to cover you. Tough luck. If you get sick, you're going to die if you don't have insurance. And this is what basically they have been over and over and over again proposing. Really mean proposals. Now, as far as the Obamacare, what happened is you saw a better coverage regarding income, better but still not good. Between 2013 and 2017, you can see there was a decrease in unmet medical needs due to cost, but still you have a significant amount of people who cannot afford to get the cost they want because of cost. So it's better. I would say the summary would be ACA, the Obamacare, improved a bit, but we can do a lot better. We still can do a lot better. The administrative costs still continue to rise, and this is hospital costs, government insurance overheads, and private insurance always has a higher overhead, showing that after the Obamacare, we still are seeing increased administrative costs. So even when they try to give more access and control some of the costs, the administrative costs keep growing. And this is a summary of what Trump is trying to do. Some of the ideas that came and were defeated so far. Basically, created this, what we call short-term, what we call them junk insurance. Increase uninsurance, undermine the risk pool. This is a longer story. I can't spend a whole lot of time on this. But basically what he wants to try to do is undo the ACA, undo the progress we made, right? So if you are sicker, you're going to have to pay more. If you are underinsured, that's your problem, because if you don't have insurance, we're not going to be able to cover you. Allow states to implement punitive Medicaid changes. In other words, he basically said the states should not increase the coverage of the poor. That's what their proposal was. And that created a big problem with many states which had already increased the coverage, and then he said, no, you shouldn't increase the coverage for the poor people at all. Let employers deny coverage for birth control. Immigrants, this is what we're dealing with right now in the United States. If any immigrant uses public services, Medicaid, or nutrition services, in other words, food stamps, as we call, bonuses to buy food, they will be called a public charge. And if your family has people in your family who are considered public charge, you can be deported. Public charge means you're costing us something that we shouldn't be providing, even if you're documented, not only for the undocumented. If you have what we call a green card in the United States. And that is creating a big problem. People are saying, well, I'm not going to go for health care anymore because I may be accused of being a public charge, and that will be grounds for deportation later. Basically, to chase immigrants, as you know, is the main agenda to keep the Republican base alive, is to say these immigrants are causing all the problems in the United States. They pay more than people in nations with national health insurance, and we have many data to show compared to all other countries in Europe. Europe is our paradise in the United States. You have better coverage, you pay less, you have more physicians per capita, etc. Overhead, compared to all other countries in the United States, that's almost triple in some cases. So if you have universal health care, you have less overhead. You don't need the insurance companies to manage decisions the way they do. Now, I'm going to end now with this idea. The main fight we have in the United States is a national health program. This group is called Physicians for a National Health Program. What is a national health program? It's basically going towards the model that you have in some countries in Europe and in Canada. So the idea is the hospitals remain privately owned. You negotiate a global budget with the hospitals, and you negotiate on a yearly basis, like they do in Canada, based on the kinds of services you provide, the types of patients you provide, the number of operations you have. And you cannot use this money to build hospitals, divert to capital, meaning to expand your facilities. You have a separate budget just for expansion or capital purchases. I'm talking about big equipment, big facilities. So this would be the idea. The hospitals would be paid globally, as opposed to today where they are paid based on diagnosis, based on fee for service provided, etc. So there are three options. What we have today for the most type is what we call fee for service, right? So what they're trying to say here is they're going to simplify the fee, and they will have mandatory assignment of patients for this. The other way is to do pay per capita, right? Which many countries do this. So people can enroll freely. There's no selective enrollment period, because in the United States, every year you have to renew your contract with insurance companies. They give you a period of time. You either renew or you don't renew. You have capitation, meaning payment per capita for operating costs, but not for capital purchase, not for profits, and not for physician incentives. In other words, we're not going to give more money for physicians. What you're going to be is a global budget based on physicians who will be paid as salaried physicians. And the inpatient care will be under the hospital's global budget. In other words, they're going to give the money to the hospital and say, you manage your budget. It's not going to be as it is today based on the number of procedures that you perform. It's the interest of the hospital then to say, I'm going to have to manage my budget better because they're not going to give me more money. So in other words, they shift the risk to the hospitals, right? And the other one is the globally budget. In other words, physicians will be salaried, and you're going to have budgets for hospital, for clinics, and for home care agencies. I believe for folks in Europe, this is not really news. I believe the NHS, a lot of it already works that way. But that's the system that we're trying to move to in the United States. This is a proposal that this group has. One of the problems, as I mentioned before, is when you move from the system we have to the new one we want, there will be about 400,000 health insurance workers. And half of the 2.6 million, that's the number of clerical administrative employees we have. So there will be a lot of people that will lose their jobs. So we need to figure out how we're going to redeploy these people to maybe expand the clinical workforce, retrain them. You're going to have to find income support and job retraining, which in the United States is not new. After the Second World War, the soldiers came. They had free college. They have subsidized housing. And we're talking about millions of people who returned from the war. It was called the GI Bill, Second World War GI Bill. It was the most successful government plan ever in the United States. The return on investment was ridiculously high. Why? Because these people came, they went to study engineering, they went to study science, and the United States has a boom in science and technology based on the investment that they had. The funding for income support and job retention, as I said, and we are talking about, in the United States, it's very common for people to be displaced from a job. 60 million people a year change their jobs. I didn't know this number. I was shocked when I saw 20 million people are fired every year in the United States. 1.7 million is the number who are fired every 31 days. So every month, 1.7 people lose their jobs in the United States. The idea being people keep moving their jobs anyway. So just to have more people displaced, it's not going to be a shock in an economy that's already functioning that way. People get hired and fired all the time. It's not really a big deal. So what is the idea? Every US resident receives an insurance card. This is what Canada does. Full coverage for everything. No co-payments, no deductibles, no co-insurance. Prescription drug formula, in other words, you have a list of drugs that will be covered, which most countries do. You can't cover for everything. And then you may have alternatives covered when patients really need, the drugs that are more expensive, the drugs that are not in the formulary, and free choice of any participating provider or hospital, as opposed to today where you have to be in a given network. If what you want is not in that network, you have to pay more, as I mentioned before, so-called out-of-network coverage. Here they would say you can choose whatever hospital you want, whatever provider that we have in the system. And the other option that we talk is a transition for those who are covered by Medicare, who are the elderly. They actually are covered by a public system, a public funding system. So many people are saying what you do is you should give this as an option. So for example, myself, I am not 65, although I'm too close to get there. But I could have a choice. If I was 55, instead of have private insurance, I could join Medicare. I could have this choice. This is what we call the public option. Give more people the ability to choose Medicare so that you increase competition with private insurance. I believe I'm going to move on because some of this I already said. And the last one is, what we're trying to do is, because the opposition to the reform is so large in the United States, so strong, they have a lot of money, they buy representatives in the House, in the Senate, what you need to do is have a lot of alternatives, and that's what the list here is. What they're trying to say here is, you should do the public option as a short-term alternative, which when we discussed Obamacare was removed from the table, from the discussion. We should have sliding scale premiums and copays according to income. The employers could offer private plans or contribute to employees' Medicare buy-in. In other words, the employer, instead of only hire private sector plans, they could actually give you money so that you join Medicare. You keep Medicare option, the Medicare Advantage option, and this become the biggest risk pool. In other words, the idea that we are working on in the United States is make Medicare available for all. Our midterm is move everybody to the tradition that we already have in place, which is very popular. The level of satisfaction is 90–95% if you ask the elderly. So move in that direction. The American people understands what Medicare is. You're not creating something out of the blue, and then it's slowly but surely you build this pool so that it becomes the major source of care for Americans. Thank you. I'm sorry if I went too long.
Did I do something? I pushed the button, doesn't matter. It's working. Should I start? Can you open up the... Oh, that's here, okay. Okay. So, Jonathan, thank you very much for organizing the seminar. Eduardo, welcome to UK. I'm Elias Kondilis. I'm a senior lecturer here at Queen Mary University. I'm a medical doctor, a psychiatrist in terms of my background, but most of my research and teaching is related to health systems and health policy. Eduardo, I've been following the PNHP presentation and the evidence that they have been producing and providing about the impact of privatization on quality, on costs, on inequalities, since the early 2000s. I remember that the first time that I saw this presentation was in 2005, 2006. I was still a PhD student then. And since then, this presentation, this accumulative evidence against privatization, this presentation starting with what, 20, 30, 50 slides, is becoming hundreds of slides, mounting evidence against privatization, but the trend remains unchanged. And this is the main contradiction here, that both in the United States, but all around the world, we have overwhelming evidence suggesting that privatization is costing lives. Nevertheless, privatization is the main policy discourse, not only in the United States, but all around the world. A massive trend, a non-evidence-based policy. It is a policy, nevertheless, that its interest is based on interest and profit making. This is the main, let's say, power that is pushing this non-evidence-based policy. I prepared a very short presentation. I'm not going to exhaust the issue of privatization in Europe. I just want to make a point. And the point is that it is true that for many years we were saying that in Europe there is a trend of the Americanization, let's say, of the European healthcare system. I'm not sure that this is the case, meaning that Europe, this idea of moving European healthcare systems have a very long tradition of welfareism, very strong social healthcare systems, social health insurance healthcare systems. Other European countries have national health systems, publicly financed, publicly provided. I think that this idea of abandoning social health insurance or national health insurance in Europe and moving towards a healthcare system that it is privately financed based on private health insurance has been abandoned more or less. So in this sense, this project of the Americanization of the European healthcare systems, I'm not sure whether this is still in place. But what is occurring in Europe is a massive trend of privatization in terms of provision of services. It is this idea that you have already touched upon, this idea of a publicly financed but privately provided healthcare system. Publicly financed for profit gaining. And this is the model of privatization and private health care that we encounter in Europe. This idea of still having public money invested in the private provision of services. I think that this is the main trend. So I will try to touch upon in this presentation what we call, I deliberately do it, what we call the two types of privatization, the direct types of privatization, the obvious types of privatization, which is the private provision of services or the private financing of services here in Europe. But I will try also to touch upon what we call the hidden, the indirect privatization, the Trojan horses of privatization, which is the main form of privatization here in Europe, which is contracting out, public-private partnerships. It is mainly these types of privatization which are the dominant type of privatizations, but which are the types of privatizations that us as researchers do not want to touch upon. Even social movements and organizations that campaign against privatization have limited information about this massive trend of hidden privatization, or they are afraid to touch upon this issue of privatization. And my main concluding point is that there is overwhelming evidence that both types of privatization, both direct and indirect, obvious and hidden, are equally dangerous, creating what Eduardo said earlier for United States, inferior quality for inflated costs. This is the trend everywhere. Now, I remind you that in terms of Europe, privatization has always been a policy, a preferred policy by international financial institutions. It has always been the preferred policy option for international capitalism and the political and financial institutions that represent international capitalism. I remind you that in 1993, World Bank, in its report Investing in Health, had made a very clear and direct recommendation that after the collapse, the dissolution, after the collapse of the Soviet Union, the preferred policy option for all ex-Soviet countries in Europe should be to abandon their national health systems, publicly financed, publicly provided, and open up the provision and financing of their services in private providers. This was a clear recommendation included in the 1993 World Bank report for ex-Soviet countries. And it is true that all through the 90s, in all ex-socialist countries, this type of reform was implemented. All of these countries abandoned their Shemenko model, their national health systems, and massively introduced, moved towards social health insurance systems and privately provided healthcare services. And these policies, in most cases, was dictated, forced to these countries through loan agreements with the World Bank and the IMF. This was a major conditionality for loans that the ex-socialist countries received during the 90s. OECD, in 2004, the Organization for Economic Cooperation and Development, which remains even today the former advisor of all European countries for the ministries of health of all European countries, the OECD, in 2004 recommended, what is the button to show the, yes. So recommended that the only way, this was their key recommendation to the ministries of health of European Union countries, that the only way for them to increase efficiency of their publicly financed, publicly provided healthcare systems would be to open them up to competition and market forces. If you want to achieve efficiency, you need to open up your public healthcare systems to competition. This was their main recommendation. Similarly, the International Monetary Fund in 2010, I remind you that the International Monetary Fund was mainly involved in loan agreements and bailout agreements in Latin American countries. Brazil had in the past a bailout agreement with the IMF. But since 2010, the International Monetary Fund was also involved in loan agreements in developed countries, including Greece, Cyprus, Italy, Greece, Cyprus, Portugal, and Ireland, plus Spain, which was a partial. So in 2010, for the first time, the International Monetary Fund was involved in bailout agreements, not with high middle-income countries or low-income countries like in the 90s, but for the first time in 2010, the IMF was invited by the European Commission to offer its advice, to participate in loan agreements in Europe's peripheral countries that were mostly affected by the Great Recession. So 1 year just before their involvement in their EU loan agreements, bailout agreements, the IMF had suggested that increasing competition and opening up public healthcare systems to competition, to private provision and private financing should be considered as a crucial component, as a core component, as a core part, let's say, element of the fiscal consolidation programs, the structural adjustment programs that the IMF would implement in Europe. So this was a policy that from 2010 to 2015, the IMF promoted, dictated through bailout agreements in Europe's peripheral countries. Competition, privatization, opening up of publicly financed, publicly provided healthcare systems to market forces. Similarly, I remind you that the European Union, consisting of 28 European countries, theoretically based on its constitution and the article more specifically 168, the European Union has, by its constitution, has the obligation of not interfering with domestic health policy, which means that by its constitution, the European Union cannot dictate, cannot force health policy changes in its member states. Nevertheless, because the European Union is a common market, and it acts as a common market that needs to promote its 4 basic freedoms, which is free movement of people, free movement of services, free movement of capital, and free movement, I'm missing the 4th, of goods, services, people, and capital. Because its main function is this idea of a free market that promotes these 4 freedoms and secures competition, despite the fact that the European Union cannot directly be involved with domestic health policy, so health policy in member states, by its own function facilitates marketization policies in the European healthcare systems. And finally, I remind you that most European countries are members of the World Trade Organization. And as members of the World Trade Organization, the majority of European countries, even since 2009, have opened up their health insurance markets to foreign direct investment. And the majority also of European countries have opened up their market of healthcare provision also to foreign direct investment and international competition. And this stands for the majority for WTO organizations. So to sum this up, I would say that privatization has been a policy that has been promoted, dictated, enforced over the last 30 years in European Union countries, dictated by major international players and actors. It is what we say, the privatization of healthcare services is what we say in Europe the 3rd wave of privatization, starting from the 70s. The first wave was the liquidation, the selling of state-owned enterprises. The second wave was the privatization of public utility services, water, energy, etc. And healthcare services is the 3rd wave of privatization, dictated in most cases by international institutions. Now, for those, and Eduardo, I think that you will agree with me, for all those who study privatization, do research on privatization, campaign against privatization, there is a common secret. We do not know how to define, we do not agree what privatization is. We have it it is very difficult to define privatization. It's even more difficult to measure privatization. Now, I'm not going to go into details about the various definitions of privatization and the constant debate about what privatization is, what is the difference between, and if there is any difference between privatization and marketization, privatization and commercialization. I won't go into this discussion, but for the sake of this discussion and this presentation, I will accept the definition by the WHO that privatization is a broad spectrum of policies that involves the transfer of assets or responsibilities of the government from the government to non-governmental actors. So practically privatization, according to the WHO definition of 1995, is a process in healthcare that will lead eventually to the increased involvement of private for-profit and private non-profit actors in the provision and financing of healthcare services. This is a very broad definition. There's a lot of limitations and critique related to this definition, but for the sake of this presentation, I will stick to it. I will accept it. Now, these are figures from the OECD. This is the distribution of hospital beds by ownership type: public, private for-profit, private non-profit. So according to OECD data, countries in Europe that have Bismarckian healthcare systems, so systems that are based on social health insurance, in these countries, 25 to 50% of hospital beds are private for profit or private non-profit. The rest is public. Such countries are France, Austria, Germany, Bismarckian healthcare systems. On the contrary, in healthcare systems that follow, let's say, the Beveridge style, that have national health systems, publicly financed through taxation and publicly provided, like Greece, Portugal, UK, Sweden, Spain, Italy. For these healthcare systems, the private for-profit and private non-profit sector owns 25 to 35% of total hospital beds. So the provision of healthcare services in Europe, there's a lot of variation between the countries, the private for-profit sector owns 25 up to 50% of hospital beds. Please note, and I'll come back to this later, that in United Kingdom, according to the OECD, there is no private for-profit or private non-profit provision of hospital services. According to OECD data, I'll come back to this. Obviously, here there's a methodological problem, and I'll come back to this later. Now, this is the percentage of the population that relies on private health insurance. Okay. So the percentage of the populations that have some type of private health insurance coverage in Europe. You can see the huge variation depending on the country. 0 up to 90% of the population has some type of private health insurance coverage. This private health insurance coverage can be either their primary source of coverage. For example, high-income groups in Germany use private health insurance as their principal. They can opt out the social health insurance system and use private health insurance as their principal and only type of coverage. In countries like France, 90% of the population has social health insurance coverage and complementary, double that is, on top of the social health insurance coverage, they have private health insurance coverage that mainly covers for the out-pocket payments that they have to pay for their social health insurance schemes. But this, on average, we would say, on average, in terms of Europe, 8 to 10% we say of the population has private health insurance on average. There is huge variation, but on average all across Europe, no more than 10% of the population depends on private health insurance, which is the stark difference between Europe and United States. United States is a healthcare system that heavily still depends on private health insurance. In Europe, the healthcare systems are still financed mainly either by taxation, national health systems, or social insurance contributions. Private health insurance plays only a complementary or supplementary role to the public coverage. There has been a discussion for us to increase the role of private health insurance. I think that this discourse is now collapsing. This idea of us abandoning publicly financed systems and going towards private health insurance systems is fading away. There's other types of privatization that are more dominant. Now, during the years of the latest economic crisis, the Great Recession, the 2007-2014 crisis, both direct forms of privatization, so direct provision of services by the private sector, direct financing of healthcare services through the private sector, during the years of the crisis, these direct forms of privatization have increased. For example, you can see in Germany, the number of private for-profit hospitals from 2007 to 2013 has increased from 15% of overall hospital beds to almost 20% of overall beds. Practically, Germany, I would say, is the only country that relies so heavily on private for-profit hospitals. In most other countries, the hospital provision is mainly relying on the public sector and the charity sector, the third sector, the non-profit one. Germany is still, we call it the champion of privatization, of hospital privatization. During the years of the crisis, the number of private for-profit hospital beds in Germany has increased significantly. This is related to the Great Recession and the fact that the majority of these hospitals were owned by municipalities. And because of the Great Recession and the high increase of their impact and their deficit, they had to liquidize these hospitals, to sell these hospitals to the private sector. Why? Because they couldn't carry anymore, they couldn't afford anymore paying for these hospitals. Similarly, the reliance of European healthcare system on private sources during the years of the crisis, the Great Recession from 2007 to 2014, has increased. 25 out of the 40 countries in Europe during the years of the crisis have introduced new user fees or have increased already existing user fees. So the forms of direct privatization are increasing during the last year, but still this is not the clear picture of privatization in Europe. What you are seeing here is the obvious types of privatization. The real privatization that is going on in Europe is what we call the hidden privatization, which takes the form of contracting out, the form of internal market, the form of autonomization, the form of public-private partnerships. And this is the massive hidden trend of privatizations, which I'll try to show you right now. Now, the first type, the most common type of privatization in Europe is what we call contracting out or outsourcing. So it is practically the situation where the public sector delegates, transfers the responsibility for the provision of services to the private sector, but the public sector still keeps the responsibility for paying for these services. So it is a partial form of privatization. You delegate the provision to the private sector, but the government or the NHL still keeps the responsibility for paying of these services. I remind you that the country, the government, the country that introduced this policy in healthcare and has set the pace, let's say, for whole Europe has been always the British government. I remind you that Thatcher during the 80s was the first one that outsourced all non-clinical services of the NHS hospitals to private providers. So instead of providing cleaning in-house, the NHS hospitals now delegate this responsibility to contractors, to private companies, but the NHS is still paying for this service. So it's not a full type of privatization, it's a partial privatization. Since, of course, the 80s, apart from cleaning, a lot of the majority of non-clinical services in UK have been contracted out, including also clinical services, out-of-hour services, which is the provision of general practitioner services after office hour, after office, out of office hours, the provision of specialist care, and the recent development of contracting out is now the outsourcing of online services to NHS patients, what we call the digitalization of the NHS. It is now estimated that today the NHS has more than 53,000 contracts with private for-profit providers. These are outsourced, contracted out services. And these contracts are worth approximately 22.6 billion pounds, which represents approximately, this is 25% of the NHS budget. Okay. So this is a massive wave of privatization. This is a hidden wave of privatization. 25%, a lot of authors and colleagues actually suggest that NHS gradually is becoming a logo. Services are provided by private for-profit companies, paid nevertheless by the NHS. So practically, the NHS or parts of the NHS are private for profit, still having the NHS logo in the sense that they are publicly financed. It is the NHS that pays but doesn't provide. It is also estimated that we spent, for these 53,000 contracts, we spent £1.3 billion on administrative costs, only just for us to administer these contracts, and more than 25,000 NHS workers, including workers working at the primary care level, are responsible for administrating, managing these contracts. Now, the second type of privatization, which is not captured by the statistics that I showed earlier, is, and it is also a massive trend that appears in UK, in Spain, in Greece, in Italy, all through Europe, is what we call the public-private partnerships. This idea of the public sector creating long-term relationships with the private sector. In most cases, these partnerships are used in order for us to build, design, build, operate, and maintain public hospitals. In United Kingdom, it is estimated that from 1997 until 2015, 105 NHS hospitals were developed through public-private partnerships. This, if you look at the overall value of these hospitals, you will see that over this 20 years period, the NHS, the initial investment for these PFI hospitals, public-private partnership hospitals in the NHS, was more than £20 billion over this 20, a second major trend in privatization. To sum this up, I mentioned here that UK has a zero, according to OECD, has a zero number of private hospital beds. The reason for this is that the OECD statistics do not consider public-private partnerships as part of the privatization process. So there is a clear issue among us, what is privatization? I insist that privatization takes the form of, we have the direct types, let's say, of privatization, which is private health insurance or private provision of services, but what is happening now is, in Europe, is a hidden form of privatization that takes mainly the form of contracted out services, outsourced services, and public-private partnerships. Now, there is a wealth, and I will finish with a few slides showing the empirical evidence, some of the empirical evidence related to the impact of privatization on quality of care and overall efficiency of the healthcare systems. Now, there is a wealth of evidence suggesting that when you move from national health systems to contracted out healthcare systems, marketized healthcare systems, when you move from public bureaucracies to complex contractual relationships in healthcare, what you are actually doing is that you are replacing public bureaucracies with market bureaucracies. And the problem with market bureaucracies is that they cost even more. There is enough evidence suggesting, similar to what we are seeing in the United States, that the first wave of privatization in UK cost over doubled the overall administrative costs of NHS. The second wave of privatization in UK tripled the overall administrative costs of the NHS. Today, the NHS is spending, this is an estimation, we don't have real figures about this, is spending approximately 20% of its overall budget on administrative costs, on transaction costs, while 40 years ago, it would spend less than 5 to 6% of its overall budget on admin costs. And this is probably related to the introduction of a huge market bureaucracy in the system. Again, this is indicative information from 1981 to 1992, which is the first wave of privatization in UK. Again, you can see that the administrative staff in the NHS increased by 40%, while in the same period the number of medical doctors and nurses remained the same or actually reduced, which is similar practically to what Eduardo was describing for the United healthcare system. When you expose healthcare systems to privatization, contrary to the popular myth, administrative waste actually increases. This is the structure of the NHS before the Social and Healthcare Act of 2012, which is the latest healthcare reform in UK. This is its structure after the reform. This is the structure before the reform. This is the structure after the reform. Do I need to comment on this? No, obviously not. This is what we call the market bureaucracy, introducing into the system complexity that is not necessary and that eventually will diverse, you will have to diverse money that you would otherwise invest on clinical services, you diverse this money to admin and management. And this probably might affect quality. Now, there is not evidence suggesting, because this was the discourse of privatization in Europe, there is not evidence suggesting that privatization increases the quality of services. On the contrary, there is some evidence, we don't have conclusive evidence in Europe. Research on privatization is not so popular in Europe. It is considered as a difficult topic, a taboo issue. Yes, probably the same in US. But at least in US you have PNHP that does a lot of research on this. Nevertheless, there is some evidence suggesting that privatization not only doesn't it increase quality of care, but there are cases where privatization can actually negatively affect quality of care. This is a systematic review of 33 studies looking at the impact of contracting out of clinical services in the NHS on quality of care. The majority of studies, almost 20 out of the 33 studies that they included in this systematic review, showed that outsourcing of clinical services in the UK had a negative impact on quality. A minority, and 10 out of the 30 studies showed that they had no, their results were inconclusive, and only a minority of studies, 4 of them, actually showed that contracting out, privatization, has a positive impact on quality. This is yet a recent study from published at the BMJ, as far as I remember, that shows the incidence of in-hospital infectious diseases, comparing hospitals that had outsourced their cleaning services and NHS hospitals that were providing cleansem in-house. The study shows that the levels of infectious diseases for NHS hospitals that had contracted out their cleaning services is actually higher compared to hospitals that would provide cleaning services in-house as a public, that is, service. And the reason for this, the explanation for this, this is not a surprise. The reason for this is that when you outsource the cleaning of NHS hospitals to private providers, what you cause is fragmentation of the services, lack of coordination. When you provide services in-house, when you have personnel that works for a long period of time on the NHS, they acquire more experience, they coordinate with the clinical staff. Why? Because you keep this within the institution. When you outsource this service, you fragment services, but also, in most cases, contractors will use low qualified personnel, or in most cases, short-term contracts, so you are losing constantly the expertise, and this explains these findings. Yet another major impact of privatization of healthcare services, again, which is in line with what Eduardo presented for United States, is that privatization comes with strings attached. And the strings attached, we call this, we have an expression in Greece, the skeletons in the closet. Okay. And the skeletons in the closet of privatization is corruption, of course. This is one of the most famous cases here in UK that captured the attention of the media. It is the case of Carillion, one of the 3 largest contractors of the UK government. So this is a private company that offers services to the NHS, to the prisons, schools, etc., etc. And it is considered one of the 3 largest contractors of the UK government. So in 2013, 2018, Carillion collapsed, went bankrupt, leaving a debt of £2 billion. Of course, it was the UK government that had to step in order to save the several public projects that Carillion was involved in, including 2 contracts for the construction of 2 new public-private partnership hospitals in Liverpool and Birmingham. This is a study from the European Observatory of Health Systems. It actually estimates that in 2008-2009, almost the levels of corruption, the levels of corruption in Europe were estimated to approximately 15 million euros, which is equal to 5 up to 6% of total health expenditure in Europe. So 6% of our total health budget in Europe is lost in corruption. The relative percentage in the United States is probably double. There are estimations saying that in the United States the level of corruption is around 10 to 15%. In Europe the levels of corruption seem to be lower, but the majority of this money, financial leakages to corruptions, are related to contracts between the public and the private sector. This is corruption in healthcare systems. Okay. Again, we don't have more detailed information about this. There are, according to this report, in 2010, there were more than 4,000 cases of corruption, reported cases of corruption around Europe related to healthcare and healthcare provision. The majority publicly financed for private profit making. So I will stop here. I think that the evidence is overwhelming, coming from both continents. The question for me, and I think for all of us, remain on how we can reverse these policies and stop these trends. This is my main, and has been remaining, my main concern. Thank you very much. Okay. So I cannot say bad words.
Thank you. I will just use the microphone so the people can also listen to what I'm saying. Thanks a lot for both for the presentations. The idea was exactly to have an overall, let's say, diagnosis of what happens in the US and what happens in Europe. And we could now, I don't know if people in Brazil would like to ask anything or to comment on anything, or here we could just discuss a little bit, or it's up to you. What, I don't know if we have anyone down there. No? Yes, please.
I have one question. Listening to both of your presentation, is you're putting together for-profit and not-for-profit, and I had discussions about publicly funded, publicly provided services with people from different political perspective, and one of the arguments is that when the state is failing, or when the state is, for example, racist, sometimes it's also good to have not talking about for-profit, I think we'll all agree, but not-for-profit is the escape for people when the government is actually rubbish.
A lot of the names of hospitals have the name of saints. They were created by the church. The idea was solidarity, mutuality. That, I believe, will stay with us for a long time. So the main target for me is not necessarily to say they are one of the same. They're both private, there's no question. But the major target, as you see in the United States, is that the real problem is the progress, significant progress of hospitals that are non-profits being bought or being actually managed in a way that they are very much like a for-profit hospital. The only difference is that they are not yet legally for-profit, but they manage the hospital the same way. So it's not really, even to say there's a big distinction between non-profit and for-profit, it's not really true. We are observing, for example, in Brazil, that we have management of hospitals that are supposed to be not-for-profit, but the logic is the same, because the power in the system is to move everybody towards the market. So in that case, we shouldn't discuss this formally. The real answer to your question is, if the public services are not good enough, what are the alternatives? I would say my first alternative is to make the public service better. Oh, but the state can't fund it. Well, if the state can fund the public, why would the state fund it? Because a lot of the issue that we said was the not-for-profit would not survive without funding from the state. So ultimately, the management of the public system may be bad, but the funding will continue to be public. So the real issue will be a political issue more than a financial issue. If it is a political, it doesn't matter to me if it's the public or the not-for-profit. Because I don't want to be in a situation where the public, the guys who are in favor of the market say, we want efficiency, we want transparency, and I'm going to say, no, I don't want that. Of course I want that. But I want that for the public system, which is democratically controlled, which has the participation of the public, in which case these issues would be not decided by managers, would be decided by groups of people who actually have power to manage these institutions. In Brazil, we have some experience with this, which is you elect people to actually make decisions about how the system should work. They are called national health councils, local health councils, state health. There are ways of making the administration and the management more transparent. Then, if you're talking about racism, this is a political issue. So the fact is, it can be a non-profit racist as well. So the real issue is, the ideology is to believe and to claim that the only way to be more efficient is to make it private. And without evidence, because what the evidence shows when you compare apples to apples, either you compare, you conclude that the for-profit are worse, or you conclude that non-profit are about the same or a bit worse. Not many examples of being better, although I would argue maybe in some cases they would be better. It could be the minority of cases, but when you compare apples to apples, which most studies don't do, because to compare apples to apples, you have to say, what are the patients that you serve, what are the patients that you serve? If they are the same, then the comparison could be okay.
Thank you very much for your question. I would start by saying that your question is valid. It's valid, and it's not only valid, it is by nature very political. Okay. Now, I will try to give a, let's say, scientific answer to your question, and I will also give you a political answer, because this was a political question. Now, first of all, from a technocrat's perspective, I would say that we need to make a distinction. Private non-profit sector is a sector that includes small social community groups that would offer services, complementary services to a public hospital, social enterprises of a small community of a village, but it also includes large, multinational, private non-profit organizations, and several other organizations in between these two ends. So private for-profit sector is not a uniform sector. We have multinationals that are private for non-profit organizations, but also we have small social community organizations. We need to make this distinction. The second, in an environment and in a healthcare system that has been exposed to competition and market forces, where you have the public sector and the private for-profit sector competing each other, and the private for-profit sector competing the private for-profit sector and the public sector in order for them to get contracts, there is enough evidence suggesting that in such competitive environment, private non-profit providers start behaving like private for-profit. There is evidence suggesting, I've seen studies from the United States, in areas where you have private for-profit hospitals and private non-profit hospitals competing with each other, and the levels of competition are very high, private non-profit hospitals, charities, will start reducing the level of services that they give to uninsured. A lot of the charity hospitals will give free services to the uninsured. In areas where the levels of competition are very high, the first thing that they do is that they start reducing the charity exactly. There is also evidence suggesting that in an environment of high competition, private non-profit companies will start recruiting employees on short-term contracts, on precarious contracts. And this is a massive reality. This is a massive reality. I have friends, we have colleagues that work in the private non-profit. The major trend in the private non-profit sector is that they replicate the types of contracts that are used in the private for-profit sector. So overall, the political answer to your question would be that I think that the public sector is not a synonym of a failure. The public sector in general, has a lot of difficulties. But I think that instead of investing research and energy on how to create alternative models, I think that our focus should be on investing research, energy, and political will on improving public services and making them more accountable, more efficient, more effective, more responsive to the needs of the population. So instead of investing huge amount of money on doing research on how we will create alternative models outside the public sector, let's use this money, this research, these ideas on how to improve the public sector, and not just, there is areas for improvement. I'm not able to defend this.
Yeah, they can also ask in Portuguese. That's not a problem. Uh, um, so for something that is quite obvious from today, we circulated this seminar through the whole university and to our students. They just don't come. So yes, but my point is privatization something old in the sense of that it's not worth to discuss anymore, because sometimes when you say, I am doing some research on privatization, people look, but this is an old thing. Yeah, this is something like sounds from the 90s or the beginning of the 2000s. So I would just like to see if you have anything, or anyone else would like to comment on this, because it is a feeling that I get from our students that privatization is something that kind of it's not discussed anymore, or in a way they just legitimize the market as that's the only way, let's say.
It's there. We cannot do anything to
Yes,
stop it.
yes,
It's
it's the only option in a way.
the only option.
Yeah.
Yes.
So I'm not sure if you would like to comment on this,
Yes,
but
I think that privatization remains a hot topic.
it remains a hot topic.
Now, I know and I'm fully aware that privatization as a term sounds like a term that comes from the 80s, from the left organizations, radical organizations, etc., etc. That people tend to, yes, so privatization might, when you say that I'm doing research on privatization, immediately they label you as a left-wing researcher. And secondly, that why are you dealing with these issues? These issues
It's gone. They're gone. Yeah,
now we have the pragmatism of the market. Obviously, this is the situation. But I think that the need for doing research on privatization, on this comparative analysis between public and the private, what is better, I think is still topical and important.
Still valid. Yeah.
I would say the United States is not out of date at all. It will never be out of date because it's part of the DNA of the society. So we're always talking about how we can make the society more private. So there's no, it's never going to be old because always the discussion is how can we make it more private? It's not the movement against privatization. It's how do we make it more? So, yeah, but in the last 3 to 4 years, the alternative coming from a candidate that says, I am a democratic socialist, whose name is Bernie Sanders, who won a lot of votes in the last election. He is considered to be one of the top candidates, if not the one who will defeat Trump, is creating a whole different movement in society that was still there, was always there, but now it's become a lot more visible to the point that we're talking about. He says, well, I want to make universal health care. I'm against the corporations. So when such a movement comes, then what was assumedly old, all of a sudden is very new. So we have to be careful with that because some people already said, and I agree very much, the new always comes out of the old. So when people start saying that it's too old, it's because they're not realizing from there we're going to get the new one. And I agree that it's clearly ideologically determined. If you are against, you are left. But I believe the issues are changing in such a way with the deep crisis of capitalism affecting societies in many different ways that I believe what will become very soon universally important is to figure out how we're going to do this because of the crisis that we're having. As you start cutting, people are going to fight back. And when they fight back, you see examples already in some countries of reversing privatization. And I believe we talked about the utilities in Germany. People are in Berlin. People start talking about getting back the water, getting back the transport. So obviously, not only privatization will become very important for the solution to the problems that it created, but it will always be part of our agenda, although the folks who are on top, they want to make everyone believe, and probably the students are influenced for this view, for the economists here and all, for no, it is a done deal, it's an old story. This is not the old story. This is actually the new story that we may start winning fights against privatization. Not now, not exactly now, because we can't predict exactly what the future will bring, but obviously the contradictions that we're seeing in society is because of that. The solution that the neoliberals propose is a solution to the failures of neoliberalism is to have more neoliberalism. But they're exhausting the sources. There's not too many more sources to go first. So societies will react, and I'm not necessarily optimistic. I'm actually pessimistic, but it is realistic to say people who fight back, and when they fight back, they're going to say, that's the problem. The problem is we gave away our rights, we gave away our resources, we gave away our services, and people get back because some of these services will fail, will go bankrupt, and that's what you're seeing in the United States. It's not sustainable. If the system they were proposing was sustainable, I would say, yes, it's a done deal. It's not sustainable, and the crises are reaching a point where people are going to have to fight back. So if the students are saying this now, stay put, because maybe in another year they're going to say, oh, professor, that debate about privatization, I didn't realize how important it is. That's what's going to happen. No, I don't. That's it.
I don't know if we can wrap this up. Yeah, in a way, it's a bit of our mission is exactly to change that in terms of teaching. Yeah, so usually that's what happens towards the ends of our modules, is that they kind of realize that this is something still important and that we can do something about. So if we don't have any further questions, I will close this here. So thank you very much. Thanks for the folks that. Thank you. Thanks, guys. Thank you. Let me just stop this so we can.